Hi, Dr. Bedrossian. I I am very honored to have you on our podcast. You are a very dear friend. I had a pleasure to get to know you more over the years, and to get to know you as a person. We became very good friends, and I love that moments we spend every time we go to a meeting and we meet each other. So I want to really thank you to make the time, especially you just flew in from China after a tour of multiple city lecturing on implant and zygomatic in particular. So welcome to the show.
Thank you very much. My honor to be here, and I appreciate you asking me to participate. So I look forward to this discussion for the next
Yeah,
time.
yeah. So we usually do a half an hour, and this way nobody get bored, and we all get on it. Your bio, for the people who don't know you, which I would be shocked if anybody doesn't know Bedrossian, but other than you are an oral surgeon and you're board certified, you've been in education for many years, and now you are at University of Pacific, running their implant center. Uh, Also, you have three great books and forwarded by great people. One of them is the icon Brian Mark, and you just came out with the recent one about zygomatic, without forgetting immediacy concept in 2022, which you were very kind in inviting me to write a chapter in it. And the most important thing, impressive thing, which I thought I know everything about you, but I didn't. You are on editorial review board of multiple great journal. One of them is my favorite, Clinical Implant Dentistry and Related Research, which has a very, very high impact factor. So, having said that, Ed, you are one of the pioneer in talking about the need for full arches and a alternative in and by classifying the posterior part. So just tell me, how did you come up with that classification, the Bedrossian classification? How did this idea come about? And
Yeah, sure. You're referring to the zones of the maxilla.
mm,
It's when I was in residency in the mid 80s, that was kind of like the beginning of implant dentistry, and not too many people were involved. But obviously, the bulk of the literature was on the mandibular hybrids, full arch reconstruction of the lower jaw, which was clearly, I mean, that's the need. When you have a severely resorbed mandible, nothing stays. So therefore, Brannemark's focus was on that. And there goes the full arch reconstruction of the mandible. Um, the next thing is, how about the maxilla? So because of the sinuses, because of sometimes the atrophy of the premaxilla, it was very difficult to place implants like we did on the between the mental foramina of the mandible, regardless of how resorbed it was. Uh, so I was involved with grafting, did a lot of Brandemark horseshoe grafting, and a lot of onlay, lot of those kinds of procedures with implants for eventual hybrids in the maxilla. But the problem with that was onlay grafts cannot have any temporary provisional prosthesis on them. So most of these patients went for 5, 6 months without any prosthesis, and therefore I never did one of those grafts in my private office. And just for your audience, I from the day I graduated, I opened up a private office in San Francisco from scratch in a building with 12 other oral surgeons. A 26-story building, 300 dentists, and 200 physicians. So it's kind of one of those crazy Armenian moves where you go in there and you open it up, right? So when I told my program director I was going to do that, he started laughing, and I said, "Why are you laughing?" He said, "You're going to have a hell of a lot of free time on your hand." I said, "Okay, what should I do?" And I was like 27 years old or something. He said, come and teach." I said, and I just arbitrarily, I said, "Okay, I'll do it, but I'm going to develop a implant program." And he's like, "What are you talking about?" I said, "I don't know what I'm talking about, but I think implant's going to be the future." So that was the beginning. So during the residency, so for 35 years, I ran the oral surgery residency programs implant on Mondays and 4 days in private practice. And I always felt that a private practice educator, yeah, hybrid, was almost one of the best instructors because what they told you to do is what they did in the office. It wasn't protected under the institutional umbrella, so they usually chose and did things that were predictable and not experimental. So the graftings I couldn't do because the patients in private practice would not go without a provisional. That's when we started, and then I was extremely lucky in the early 90s and was mentored by PI Brannemark and spent a lot of time working with him and collaborating. One of the things that we did was started using the zygoma implant or tilted implants without grafting so that we could immediate load these patients. And one day, we had some guests at the residency program. And as my resident is presenting and he's systematically going through the x-ray and, this and that, this and that, they were like, ooh, ah. I said, what are you guys ooh and eyeing about? Oh, that's such a nice systematic way of talking about things. And for the first time, we stopped and we said, oh, wow, we do have a systematic way of talking about it. When you are developing something, sometimes you don't see it. These guys
Hmm.
made us see it. So I sat back and I said, oh, yeah, that is true. We do this. So I wrote the paper on treatment planning of the edentulous maxilla. And it was primarily for my residents' benefit. But the maxilla has the premaxilla, cuspid to cuspid, and then bicuspid area, then molar area. So we just said zone one is the premaxilla, zone two is the bicuspid, zone three is the molar. Availability or lack of bone in any of those zones is what determines whether you do tilted, axial, or zygoma implants. So it made it very easy to pick up an x-ray and say, I think I'm going to do this. And then you spend the rest of your time looking at scans and clinical examinations to confirm if what you thought was actually right or not. So it kind of came about as an accident, like a lot of good things are so simple and basic, but when you put it together, you go, wow, that's great. But it's really a very simple idea. Yeah.
No, it's great. And since you mentioned something, it's the tilted implant. Now, when we were training, I trained early 90s. We were how parallel we have to have them. And you can't tilt them, you cannot do this and that.
Right.
Here you are, you started talking about tilted from the late 80s, early 90s. And
Right.
I'm sure you've faced a lot of resistance and people saying you're crazy and stuff like that. So can
Yeah.
you tell us how was that journey?
Sure.
How did you think about tilted when everybody was not talking about tilted?
Well, you there was a couple of us, who were working kind of on it. We didn't really know each other, but we found out like 2, 3 years into it that it's not just me doing it. And a couple of people who in the early times published on it, Aparicio from Spain, and then Kirkmanoff, who actually was a oral surgery program director in the United States. And I think if anybody's going to look at a literature, because what you said is exactly right. The especially Brannemark, right? All this stuff comes from his research. But you axially load an implant. So the implant's placed right underneath the tooth and you actually load it. So if you're going to tilt it, how could that be? Well, Kirkmanoff did a very nice study that showed that whether you tilt it or not tilt it, whether you axially load it or not, or off axis loading, the loads are the same. Now,
Hmm.
our audience should say, that's impossible because I haven't told you the next part of the sentence. The loads are the same as long as you have cross arch splinting. So tilted implants, whether it's the regular tilted implant like an all-on four kind of a thing, or a zygoma, which is basically the same tilted, it's just the other way around.
Yeah.
They only work long term with cross arch splinting. And then, this is kind of like one of the discussions that come at the end of one of these talks is cross arch splinting always is thought about as, a time of implant placement and time of the healing of the implants and all that immediate loading. But it really also applies forever and ever and ever. The success, if I was a restorative office and I had a lot of these patients, my number one protocol on follow-ups would be to check to make sure prosthetic abutment screws are all tight and we have cross-arch splinting. Not the typical cliche of hygiene. I
Mhm.
mean, yes, hygiene is important, but if the intaglio surface is made properly against the soft tissue, there's no gaps, there's nothing to get in there. But we can't delegate these follow-ups to auxiliary staff and not document in the chart if the prosthesis is stable, not stable, because lack of cross-arch splinting is a prescription and for failure. So I think that's what people have to know. That's why you can load it, because it's cross-arch splinted and no
Interesting.
other reason. Yeah.
Yeah. But that opened later on the whole thing that now so many people are involved in full rehab, maxilla, and simpler approach than doing the grafting and months, as you said. Um, so so that was an interesting journey because there was different schools of thoughts. You were talking about full immediate loading, cross arch. People were doing the staging. This is how we were trained. Keep some teeth, make it temporary. It takes forever. Cost is astronomical with time and all. So in a way, you started it. You believed in it from the beginning, and then we ended up with you getting involved into the zygomatic. And the zygomatic for years was under the radar until recently it exploded.
Yeah.
And in any and if we need to give anybody a credit is you, because you've been very you pushed for it. Uh, you designed implants for zygoma. You've actually been a key opinion leader for very, very important companies. One of them is Nobel. You were D1 for Nobel to train people. Then you moved to Stroman, and you've been very, very instrumental in getting Stroman to have zygomatic, which is a big challenge. This is like you have a Swiss mentality that did not exist about it. They follow user by the book and so on and so forth. So tell us a little bit about that story because that's a
Yeah.
fascinating.
No, thank you. I will. So, tilted implants took us back to people who had bicuspid bone in the bicuspid area. But what if you didn't have bone in the bicuspid area? You didn't have any bone in the molar area, or you had complete maxillary atrophy, you had no alveolar bone at all, just big
Mm,
sinuses. Well, again, by dumb luck, being mentored by PI, knowing zygoma implants were invented for primarily for oncology reasons, maxillectomy patients. That's why you hang the implant here, and then you have a obturator or whatever attaching to it. Then in the early 90s is when he thought, well, why don't we start treating non-oncology patients? So we started off with severely atrophied intact maxillas, and in 96 was the first US course that we put together at Kenji Higuchi's office in Spokane and kind of launched it here in the US. As you said, the first time I presented at the American Association of Maxillofacial Surgeons meetings, they all thought I lost my mind. But at that time in the 90s, the implants have evolved. In the 90s, we were talking about trying to get osseointegration. If we got osseointegration, we were all happy. Then some implants were like this, some were like that, and the restorative people were complaining, and our excuse was, well, I put the implant where the bone was. In the 2000s, it became very clear that you can't just put implant where the bone was. You have to put an implant in a restorative position, you know.
mhm,
So, we went ahead and incorporate the zygoma implant to be exactly where an axial implant would be in the molar region, for example. If you didn't have an X-ray, it would look exactly the same. So
mhm,
that the workup for it and everything else was the same. Except, as I said, we started with extremely atrophied patients. If there's one thing your audience, I want them to get from this podcast, talking about severe edentulous maxillas, even mandibles with maxillas more, is when we all think of maxillas resorbing upwards and back. We rarely think about the horizontal resorption. Okay.
Correct.
But there's a lot of horizontal resorption. On a non-resorbed case, the screw access holes, central fossa of the molar, cingulum of the anterior teeth, are directly over the ridge because the bone is not resorbed. But on a severely resorbed case, where the maxilla becomes like a raisin, a grape becomes a raisin, the arch form doesn't change. So when you put the implant on the ridge, it is 5, 6, 7 millimeters palatal to
Hmm.
the central fossa because the ridge is there, not because the zygoma implants are palatally placed,
Yeah.
is because that's where it is. And people who don't really understand fully edentulous reconstructions miss this point. So they come up with um, zygoma implants are palatally placed, therefore we should cut the alveolar ridge, we should do this, we should do that, it should be prosthetically driven. That's nonsense. Prosthetically driven is a term that kind of became stale 30 years ago. It was applicable in 90s, where you put the implant any which way. But everything should be prosthetically driven. It's just like you can't even think of putting implants in unless you're thinking prosthetics. So uh, I should be happy today that everybody has adopted the zygoma implant, but I'm not because there are a lot of individuals on the Instagram, on Facebook, whatever, showing cases. And transnasal implants is one of them. Transsinus implants is one of them. This ridiculous techniques, thinking that anchoring 2 or 3 millimeters a screw into some little bone is going to somehow last. And all the references, if there's an article or technique article about this, the references are all given based on the Brandenmark protocols or the most traditional protocols, and they're not doing that. So they're modifying and bastardizing the procedure, and I'm afraid it's going to end up with higher complication rates, and then the implant or the treatment option is going to get a bad name. So I'm trying to right now herd in some of the my colleagues. Um, Implant companies are making zygoma implants with no thread on the implant platform.
Hmm.
Okay, how does that even make sense? And if I may just take 2 minutes, explain one point to your audience,
Absolutely.
I think it will make sense. Frank Renoir from France has shown, and he's got a textbook on it. When you put, as you said, axial loading, when you put an implant in and you load it, it's the implant platform, which is the ridge crest, and the first 5 millimeters of the threads that takes all the occlusal and lateral forces. So it's the first 5 millimeters of the implant that takes the occlusal and lateral excursive forces. Why would that change if you tilt the implant?
Mm. It's actually
Why
more.
would that why would that change if you put a zygoma in? It's the first 5 millimeters of the implant.
Yeah.
So when you cut the alveolar ridge, when you're putting zygoma implants in, all for this nonsense of prosthetically driven, blah blah, whatever the hell I say, or they put transnasal implants in. I actually did something that I don't do usually. I reposted a picture. I covered up whose it was, the name, but I reposted a palatal picture of a transnasal case where the narration on this post was consistency allows for predictability, blah, blah, blah. And then he shows transnasal implants with like, I don't know, 7 threads out of the bone placed in the palate. So somewhere, if they showed the X-ray, maybe 2 or 3 millimeters was in bone at the apex, and that was it. I mean, you have no idea what you're doing. The biomechanics do not make sense. What are you doing this? So everybody has gotten involved with implant treatment planning. Everybody's became a professor. Everybody's teaching without any um, real discrimination of the materials. And unfortunately, and I'm not saying this maliciously, but I hang out with these guys all day long. Millennials and some of these younger students um, feel that challenging something that doesn't make sense to them maybe is impolite.
Mm.
Maybe they might hurt the feeling of the person who's telling them nonsense.
Yeah. Yeah.
The way we were raised was when 2 plus 2, somebody's telling you 6, get aggressive and find out how the heck can that be because your mother told you it was 4.
Indeed.
So how could
Indeed.
that
Yeah.
be?
Yeah. Yeah. Yeah.
Yeah.
No,
So
it is. It is. It is. It is. You're right. You're right.
you know,
So but social media, TikTok, all of these things have allowed a platform or gave a platform to a lot of people that it's misleading in everything.
Yes.
They put an implant and then they immediately they go and they show the next ray of it that they placed it, and somehow that's the norm. Um, so, a zygomatic implant is really a let me put it differently in a polite way. The scope of practice to place a zygomatic implant, and it's really a niche. It's not for everybody. Yet we go back to the same thing. Implant companies are opening courses, and they are inviting people to come and learn how zygomatic implant. I've been doing implant for 30 years, and I did not place one zygomatic. Not that I'm afraid, but I I think that this is, somebody does it for living. It's different than me that I do good stuff. Let me stay with my stuff.
Right.
And I'm known to be aggressive. So the question is, talk to us about the risks of putting a zygomatic if you don't have a good training.
Right. Well, one of the meetings, there was like four different major meetings in China, and one of them I think was on Saturday. They asked me to give a complications of zygoma lecture, and obviously orbital involvement in the eye is number one topic people talk about. And I started off by saying, in order to place a zygoma implant in somebody's eye, the person who's doing the surgery has to wake up that morning and say, you know what I'm going to do today? I'm going to put an implant in somebody's eye. It has to be intentional because it is impossible to put a zygoma implant in somebody's eye if you're following the protocol. It is absolutely impossible. So whoever does it doesn't know what they're doing. They don't understand the knowledge, the anatomy, and everything else. Zygoma implant is not an implant, right? Implant traditionally is talked about a endosteal screw that's placed in the alveolar bone. The zygoma implant is placed in the alveolar bone, but it goes halfway up the face and includes the a maxillofacial structure. Happens to be the zygoma bone of the maxillofacial, bony structures, and it involves the sinus. The sinus involves the paranasal sinuses. So there's a whole paranasal sinus complex. There's a whole maxillofacial bony structure complex. There's whole maxillofacial space infections, canine space, buccal space, all those spaces that are very unique to this surgery and not unique to, have nothing to do with regular implants. So lack of that knowledge, I don't care about training because the dentistry, everybody wants to train. Training means knowledge, lack of understanding what you're doing first before you do it. Everybody wants to know how to do it and then hope that they figure out why they're doing it. You have to first understand why you're doing it, how you're doing it, what it is, and then do it. So, this complex and it almost okay, I have never done a pterygoid implant. Never had the interest to do it. Never did it because I know what's in the pterygomaxillary fissure from all the Lefort ones that I did. The maxillary artery, and if you hit that thing, you're done. So I never had the guts. And as you said, just like you, I'm known to be aggressive with zygoma implants and quad zygoma. How could you not do a pterygoid? Because I am scared. Not scared because it's a blind procedure. I'm just drilling somewhere, and then I hope I'm in the right area because my target is very, very small. And if I'm not in the right area, I got a big artery up there that's not very happy with me if I touch it. So I've never done it. Do I know how to do soft tissue grafting? The answer is yes. But when somebody needs a soft tissue grafting, do I see the defect the way you see the defect? Impossible, because that's your field. That's what you do. Can I technically maybe do it and kind of make it look okay? Yeah, but I've done it. I've done plenty of soft tissue grafting, but that's not what I do. If somebody needs it for cosmetic reasons, functional reasons, whatever, I don't say, oh yeah, let's book them for that. No, it goes to a periodontist, right? So one has to know, just because I'm interested in doing something doesn't mean I should be doing it, Yeah, I'm interested in how great it is to do, a cardiac bypass. So yeah, yeah. So I'm gonna go practice that now, doing it? No. So people have to, if you don't know what you don't know, then you start doing crazy things. I know I give you exact again, the pterygoid area because people can relate to what I'm saying. I know what's there. I know what complications can happen. I choose not to be involved with it. And then when I look at the evidence, I don't want, first of all, I've never seen a good course on transnasal or pterygoid implants, for example, a course that says how you do this. Then I've never seen a discussion on what the complications are and how you manage it. And I've never seen a 2 year, 3 year, 5 year with radiographs, with follow-ups on its success. All I see is let's do it, let's do it, let's do it. And then when you ask somebody, what's your failure rate? First they tell you, oh, nothing. And then you say, are you serious? You have no failure. Oh, yeah, yeah. Okay, okay. So what's your failure rate? 30%. When somebody says their failure rate is 30%, that's
That
like
means it's
somebody
much
telling
higher.
you yeah, their net worth is $1 billion. You got to take four zeros off and then take the square root of that number, and that's the real number, right? So
Yeah,
there, yeah, so it's probably very much higher than
yeah. I mean,
30%.
30% is extremely high in implant
Yeah,
dentistry. So, and
yeah,
two, they came up with the pterygoid. Actually, I was going to ask you. You read my mind. Pterygoid. They made them also polished surfaces, and which is a little bit interesting because that's the worst part of the maxilla, the softest bone in the maxilla. So that's where you need the most roughened
yeah.
surface.
Yeah, I think the apex they keep roughened, but the rest of it is traveling through soft tissue,
Mhm.
and it just I mean the whole concept today, if we there's a I don't want to overwhelm with this part of this conversation, but there is a philosopher, two guys, Macintosh and I'm blanking out on another guy's name, in the 70s that talked about human infallibility. Why do people make mistake? And actually, Frank Renard and I, last month, we published a paper on this, but we kind of um, uh, disguised it as a sinus lift paper, but it was exactly what I'm going to tell you right now. So it's about infallibility. Why do people make mistakes? And it's two reasons: ignorance and ineptitude. Well, ignorance is not a derogatory term. It means, if in 1920s, doctors didn't know smoking and cardiovascular disease was a direct connection. So there's even a doctor smoked, right? But today, if a doctor smokes, you say, what the hell is wrong with you? Don't you know? I mean, that's not good for you, right? Or if you have a high, 200, 300 glucose, you go, hey, why aren't you taking medicines? But maybe in the 40s, that wasn't so understood. So doing the wrong thing because of ignorance, not knowing, is excusable. But doing the wrong thing
When you
when you
know,
know what the right is, that is not, and that's
yeah,
ineptitude. And that's what's happening right now in our profession, which is sad because, as Brandon Mark said, you're doing this podcast tonight. We are going to, we study, we write textbooks and all that. Why? To treat the patient better. If we do something wrong, we always think we're talking about our own ego. You are hurting another human being, and that's why you
indeed,
shouldn't. That's why you shouldn't be doing it.
indeed. But that is where the ethics of do no harm that we
Yeah,
make the swear of it on the oath, and we are doing it. And people will hear us. They will say, "Oh, look at those are specialists, and they wanna keep things for themselves." Unfortunately, we've seen it over and over. And just like you, I've worked. I taught a lot in continuing education. I
yeah,
get to a point I would never teach continuing education anymore because I don't feel comfortable of knowing that I'm doing the right thing. I mean, it takes a resident 3 years for us full time to learn the basic.
yeah,
First year, they puddle, and this is you go take a course on the weekend. You start putting implants, and especially zygomatic implants, for
yeah.
God's sake. Yeah. So
No, I mean
yeah. So
this
we've
relationship.
hmm?
No, this relationship between um, industry and clinicians like us is
Hmm.
a very interesting relationship, and I've been in it because of Brandenmark. I mean, Nobel Pharma existed because of PI Brandenmark, right? Brandenmark implant system under the Nobel Pharma whatever. Um, any of these companies are as good as their KOLs, their clinicians. And it's kind of a catch 22. You need them to be able to do allow you to do R&D to modify implants to see what works, have a specific abutment, have this and that. And they need you so they can sell their stuff. Okay, that makes sense. But you can look at that in a very positive way. Only if the key opinion leader, the KOL, the clinician, is honest about it. You know,
Hmm.
if just like PI was, if the, I mean, everything we're talking about today, how many implants do you put, distribution along the arch, cross arch splinting? PI talked about this in 1970s. There's nothing new, you know. He did a paper in 1978 that said it was a 68 to 78, a 10-year paper that put four or six implants in the maxilla, four or six in the mandible for full arch reconstruction. The reason why he put six, I mean four, is because the arch width was very small because it was much more atrophied.
Gotcha, yeah.
So the implants were 7 or 10. The reason why I put 7 is because it was so resorbed you couldn't put a 10 in. So that was the study, right? When you look at the numbers, maxilla mandible 6 or 4, it's the same. You can exchange those numbers. They're like 1 or 2% different. So we already knew that 4 or 6 work for like 30, 40 years. So I tried to follow. One of the reasons why I'm been involved with education is because I would like to be able to make sure information getting out there is correct. Because as you and I know the ethics of it, as you said, the morals of promoting something that you know is probably not well studied. Well, in defense of the industry, they don't know that. It's impossible for them to know that because they're not clinicians,
Yeah.
you know?
Hmm.
So they have no foresight as if this is a good idea, not a good idea. If you went and told them we should put 12 implants in every maxilla, they're going to say yes, because instead of selling 4 implants for every case, they're going to
Yes,
sell 12
yeah,
implants.
12 implants.
And I
Yeah.
used to joke, yeah, I used to joke with Nova Biocare when we were doing this early 2000s. I was saying, guys, I want you to support this project, but it's not good for you. And they're like, what are you talking about? I said, well, because all I'm going to say is you're going to use 4, not, 10.
And
So if you have the right KOLs and if you have a right CEO of a company that has a vision long term, we are going to be in business as Strawman or as Nobel or as whoever if we manufacture the hardware that the clinician can use for predictable outcomes, then they're going to use us. If that's their thought process and they pick the correct KOLs, then the industry is happy, the clinicians are happy. We get to, like all the development of the new scanners and everything else, right? The intraoral scanners, the
mhm.
photogrammetry, whatever. They're all being developed by clinician input and
Yeah.
making life much easier. Like right now, the PIC photogrammetry machine, you don't need that big camera anymore. You take your iPhone and you take a
Mhm.
picture of that. Well, where did that come from? From clinicians who looked at that and said, it's a good idea, good machine. Let's make it user friendly. So it could be good and bad. If they pick the wrong people, then you're gonna have like used car salesman idea, and you're gonna start putting in this trans sinus and this stupid implants. But if you are following evidence-based stuff, I think industry and clinicians can be working synergistically together.
So I want to pivot down and talk about uh, how you can build a practice in the full arch, because a lot of people are want to do it, and so on and so forth. You were unusual that you an neurosurgeon, but you helped the general dentist restore the cases. You were one of the first who did that. And it was regular means, dentures and converting them and all of that.
Yeah.
Now we have a whole digital Pandora, and your son is very, very active, and just that they know that uh, his son is a Dr. Bedrossian Jr. is a dentist, a prosthodontist, practicing the same building as he was practicing, and he is a, superstar now in digital input in the full arches. So today is fun to do full arches
Yeah.
versus when
Well,
we started. Yeah.
yeah.
So what
Well,
is the advice for you? Sorry.
yeah, I will. No, that's a good thing you bring up. I still as you said, I right now run the university's implant program. Plus I established the university as an ITI scholar center. So I have actually a periodontist from Venezuela, that's Argentina, that's finishing up with me, and I'm going to
And your
get a
scholar.
yeah, I'm going to get a prosthodontist who's finishing up University of Boston for this new year. But still, I'm in my private practice 2 days a week, so I do work with my
Mm.
son weekly basis and do cases. And yes, he's the kind of like one of the gurus of digital, restorative, along with Panos and Kostos and some of these other guys. However, digital dentistry, that's just, I don't even know what that means, but digital machinery is dumb, has no brain. Somebody has to put analog information into that thing. Somebody has to take that beautiful intraoral scanner and know that there's a scan path. I can't just stick that thing in somebody's mouth like a toothbrush and go like this and say I scanned it. There's a specific scan path I have to follow. Somebody has to say when I put somebody in the iCat machine, I should have it all, the balance correct, whatever, whatever. When I do a verification jig on my prosthesis, yeah, everything is fundamental dentistry. I'm an oral surgeon who went to oral surgery at times when my practice for the first 15 years was mainly orthodontic surgery, trauma, this kind of stuff. Until medical insurance just dried out and patients could not afford stuff, and when we got into dental alveolar surgery, right? So being able to understand um, that analog fundamental knowledge is what allows you to be the reason why I told you that about my original career was this. Restorative dentistry is what I ran away from, right? To become a maxillofacial surgeon. But once I realized it was implants, I realized it's all about teeth.
Mm.
We are the foundation man. How could you pour a foundation not knowing if the contractor is building a two-story building or a 10-story building on your foundation? So I made it my business to know restorative. And I built my business. If somebody said to me, "What is your silver bullet?" My silver bullet is I understand treatment planning. And what is treatment planning? It's basically fundamental dentistry. And who is the guru of fundamental dentistry? Prosthodontists. That's why I told my son not to go to oral surgery. I said the future of, if you, I, is I think future is, you know, dentistry. And if you're going to do it in as a prosthodontist, where you are taught to critically think, evaluate evidence-based papers critically, where you don't compromise. You know what is the right and what's the wrong. And once if any surgeon understands treatment planning, then that's the number one way of building your practice. How? By like I did. It's a lot of full arch cases, implant things, as you know, are surgeon driven. So you go out with your referring doctors and you tell them, hey, let's reconstruct this with 2 or 3 implants. Let's reconstruct this with a full arch implants, whatever. And if they have no knowledge, then you walk them through it. You have to know about the abutments. You have to know about laboratory techniques. You have to know about digital workflow, analog workflow, how to troubleshoot. And people will say, well, why? That's their problem. Well, if you are lucky to have 3 or 4 Armands that you're working with, you are very, very lucky. I have 2 or 3 people in the city of San Francisco that we don't have to say anything to each other. We just look at the patient's x-ray. We know exactly what each one of us is going to do. But that's not
Mm.
true for the rest of it. The rest of them, you have to, it's not babysitting. I think it's just pragmatic way of handling it because you win as a surgeon, the restorative doctor wins as a restorative doctor, and the
Absolutely.
most importantly, patient wins because they get good care. And then the third part that we don't talk about a lot is you have to recruit good laboratory technicians.
Correct.
The laboratory technician of today has to be a computer scientist. The ExoCAD, the iCAD, I mean the co-diagnostic, all these programs for digital wax up, digital implant fabrication, printing, these all require a relatively savvy guy who understands and so yeah, today's team is a little bit different than the team when you and I were, at this point
Yeah.
of our career. But yeah,
Yeah.
but it's still fun.
Yeah.
But they all have to understand fundamentals. No computer's going to tell you your tooth to lip ratio is not correct. They're not going to tell you that.
Yeah,
You're just
yeah.
going to
No,
show it to you.
yeah, exactly. That the AI is not going to take over in our
No.
world, this thing. And it's interesting that you said all of this because this is going to be part of the lecture that I'm going to give when we're going to meet together in Arizona soon about business and immediacy because there is a very important thing. All what you're saying is if you really want to get involved and do a full arch every month, one or two, or three, or even every day, that you are needing to have an investment in having all of these things in house because otherwise it will become too difficult to be fulfill those cases.
Yeah.
And that's something very important. Ed, is always a pleasure to talk to you. I love your energy. It's funny. I used to think I'm the most opinionated person because that's what they used to call me in New York until I met you. Oh my God! Thank God,
What do
somebody
you
else
mean?
can take
Look how calm and how
yeah.
how open I am. And I just
Now you
gave you
are,
a
now you are,
14-hour flight.
but yeah, no, but
Imagine. Yeah.
exactly. I mean, I have to say, you are other than a friend, but even not because we're friends, you would do that. You would do that because you love teaching, and I really admire that you were sending me emails from the plane saying, "Don't worry, I'm going to be on time," and so on and so forth. So I really appreciate it because you're
Okay.
dedicated. Your this dedication pays, and thank God we have people like yourself that keeps this profession going forward and having a new generation like Armand. Just that they know his first name is Armand. You can follow him also on Instagram. Actually, he doesn't need anybody to say he has huge followers, but he's a really fascinating person and a very humble person when you meet him in person. So, Ed, thank you so much. It's always a pleasure, and I look forward to see you in a couple of weeks.
Thank you very much for having me, and I look forward to seeing you in Scottsdale for sure.
Okay, all righty. Take care,
All right,
my
take
friend.
care.
Bye
Okay.
bye.
Bye.